Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into this latest video. It's a very interesting case of a patient who, on first appearance, just attended with a blocked ear full of earwax and a bit of dead skin. However, as we removed this occluding wax, it revealed the patient actually had a cholesteatoma. So I'm just going to explain what a cholesteatoma is, and in the meantime, obviously, you can continue to watch the procedure, and I'll come back to this in a moment when the cholesteatoma is revealed. Behind the eardrum, we have what we call the middle ear cavity. Now, the middle ear should be air-filled, and the air pressure behind the eardrum in the middle ear should be the same, the equivalent to the air pressure in the atmosphere. And what regulates the air pressure behind the eardrum in the middle ear is the eustachian tube. So that's a narrow tube, a narrow orifice that connects the middle ear to the back of the nose and nasopharynx. The eustachian tube is typically closed, but during brief moments of swallowing, yawning, chewing, it momentarily opens, and it then allows the middle ear pressure to equalise. So if you think about when you go on an aeroplane, when you descend, your eardrum gets pushed in because of the air pressure. And we then close our mouth, pinch our nose and blow. It's called the valsalva. We force air up the nose, up the eustachian tube to pop the eardrum back out. Now, if that eustachian tube gets blocked at the back of the nose, there's no air behind the eardrum. The eardrum gets sucked in as a result, so it's negative pressure, and it's like it creates a vacuum, a suction. And the eardrum gets sucked in, and that creates a pocket at the top, a retraction pocket. Now I'm going to come back to that in a moment. So you can see I've removed the blockage, and on the left-hand side here, we've got this dead skin. It's really hard and crusted, and I tried to remove it with the fine end, or I think originally with a standard Zollner suction probe. I'm now using a fine end, and the patient found it very, very uncomfortable, and he twitched, and you can see he just shook there again. So what I've done now, I've put some olive oil in just to soften this to see if I can help remove it. And at the moment, I'm still none the wiser. I'm just thinking this is just a bit of dead skin that's crusted at the roof of the ear canal. But as I start removing this and manipulating it, the cholesteatoma sac is revealed. So when the eardrum, when the eardrum is sucked in, we call that a retraction, and the eardrum gets sucked in at the top, in the attic, what we call the posterior superior region of the eardrum. Now, the ear canal and the outermost membrane of the eardrum is made up of a skin, a very thin layer of skin, epithelial skin. And as this skin dies and sheds, it should migrate out of the ear naturally, a bit like a conveyor belt. However, when you've got this retraction, a pocket at the top of the eardrum, this skin gets collected in the pocket. And when this skin gets collected in the pocket, it gathers, and it gets bigger and bigger. And this skin then becomes infected, and we call it a cholesteatoma. It can be really, really dangerous, guys. And this skin sac then grows inwards into the middle ear, and it can go upwards towards the brain. In the worst case scenario, it can cause meningitis, brain abscess. It can be really, really serious. And when you have a cholesteatoma, the patient now has to have a CT scan, and I'll come back to the moment. So you can see here, then I also, after the olive oil, I put some sodium bicarbonate drops just to soften this, and you can see the skin's formation of the skin sac there. Now, this crusted skin, so the cholesteatoma not only can grow inwards, but sometimes the tip of it can grow laterally outwards, and it solidifies, it crystallizes, and you can see I'm just gently manipulating this, and the drops did help. Now, it's important for me to remove this because we need to, at the moment, I'm still not 100% sure what's going on here. Is it just there's some dead crusted skin? Or is there a cholesteatoma? We don't know. Now, the patient has actually got glue ear as well. They have got fluid behind it because the eustachian tube is blocked. And going back to the eustachian tube, when that's blocked, not only does there's no air behind the eardrum then gets sucked in. Eventually, fluid that would normally drain out of the middle ear via the eustachian tube can collect, just like if you've got a blocked drain pipe in the kitchen, and the fluid builds up behind the eardrum, and it then gets infected. It becomes viscous, like a glue substance. We call it glue ear. And this patient's eardrum there is glue ear behind the eardrum, and the eardrum is bulging. And at the top here, we can see we remove the tip of the cholesteatoma. And and I'm going to annotate it, so if you keep watching, you'll see an annotation. That's a cholesteatoma sac. Now, you don't remove that in a normal appointment like this. The patient has to now be seen by an ear, nose and throat doctor. And typically what happens, they will then send the patient for a CT scan to see how big this skin sac is in the middle ear and where it's growing. Sometimes it can get sucked upwards, it can get sucked in the mastoid atrium. So behind your ear, if you just tap it with your finger, there's a bone there called the mastoid bone, and it's almost like a hollow bone. It's got a honeycomb structure, and so in the case of this patient in the right ear, if we imagine we go through the eardrum and we turn left and we turn immediate left again, that's the entrance to the back part of the mastoid, and it's kind of a hollow area, and a cholesteatoma sac and the eardrum can get sucked into that atrium. And so a CT scan is most certainly required to evaluate the size, the severity of this cholesteatoma, how large it is, and most likely will have to undergo surgery. And what the ENT surgeons do, first of all, and it's all done under general anaesthetic. This is not done even under local anaesthetic. This is done under general anaesthetic. And if the sac is quite big, they will, from the ear canal, make an incision, make a flap so they can turn the eardrum into a door almost. They make an incision around it and they lift the eardrum forwards like a flap. And then you get access to the middle ear. And they will also typically then drill the bone behind your ear, the mastoid bone. We call that a mastoidectomy. And that's about 3 centimetres inwards. It's a big, it's not, as I said, you can't do this on the general anaesthetic. I've been criticised before for not to remove a cholesteatoma. But as I said, this is under general anaesthetic. So the ENT then drills the mastoid bone, clears it all out, because the sac can get, as I said, sucked into the atrium. You can only really visualise that by drilling out the bone externally, transcranially. And then they'll remove any cholesteatoma there. And then typically it's sometimes, depending on whether it's a closed or open approach, they might have to have revision surgery just to make sure there's no skin left behind and it's not redeveloped itself. So we've referred the patient to ENT via GP, but I have, if possible, recommended they go privately, at least for the initial consultation, just because the waiting list at the moment is stupendous. It's like 9 to 12 months, if not more. So, and you don't want this cholesteatoma getting worse. You really don't. So I hope you enjoyed that video, guys, and a bit educational. Take care, and I'll speak to you soon. Bye.